Hi, good afternoon. I'm Dr. Saxena here, the study coordinator for therapeutic nutrition course. We'll wait for all the students to join in and then we'll start the session. Okay. So, good afternoon, study group, and welcome to the course on therapeutic nutrition. Can you hear me? Hello?
Yes,
yeah, okay. So the thing is, the first lecture was meant to be taken by Dr. Dhabi from Ahmedabad, but he's probably stuck up in the hospital with something important. So I'll start with my topics. And then if he joins today, he joins today. Otherwise, maybe we'll have his lecture later on in the week. So welcome all of you to the therapeutic nutrition course. I'm Professor Anita Saxena from the Department of Nephrology, your course coordinator. We have planned a schedule for 7 days, and we've tried to cover most of the medical specialties where nutrition plays an important role to help you be an all-embracing, accomplished medical luminary. At the end of the course, the recording of the lectures will be available on the website. And I would love to have your feedback on the course. And you are at liberty to contact me as and when you like and you require my assistance. So let's make this course a positive learning experience. Now I'll share my slides. Right. So I'm going to talk to you about nutritional management in pre-dialysis chronic kidney disease and maintenance dialysis. So the two lectures I've combined into one. It's going to be a long lecture. Now, why is nutritional intervention required in CKD? We know that kidneys are key homeostatic organs. Among their many functions, kidneys maintain body's balance of several minerals like sodium, potassium, and phosphorus. Patients with chronic kidney disease and end-stage renal disease are prone to uremia-induced hidden conditions like oxidative stress, inflammation, metabolic acidosis, mineral imbalances, which greatly contribute to morbidity and mortality. Now, kidneys, we all know, are responsible for a series of life-sustaining mechanisms like excretion of body waste, nitrogenous waste, maintaining electrolyte balance or maintaining pH balance, then blood pressure control, and hormone, and they also synthesize hormones like EPO, renin, and vitamin D. So individuals with CKD can have multiple comorbidities, including hypertension, type 2 diabetes mellitus, cardiovascular disease, and obesity. Now, the term renal disease embraces a number of clinical conditions whose common feature is loss of kidney function and development of cardiovascular disease. Another common feature that these conditions share is malnutrition. Now, as kidney disease progresses, metabolic changes take place in the body like inflammation, oxidative stress, insulin resistance, impaired glucose metabolism, protein catabolism, endothelial dysfunction, and lipid abnormalities. So if you have a look at this figure is showing you the conceptual model of PEW, which is showing you the relationship between progression of kidney disease and contribution of factors like inflammation, uremic toxins, hypercatabolism, and malnutrition to physiological and nutritional dysfunction leading to cachexia, fat, and lean body mass loss. Now, what causes malnutrition in CKD? It's basically uremia. What happens is uremia induces imbalance in the hormones like leptin, ghrelin, tryptophan, and serotonin, which causes anorexia. And so the patient has reduced hunger. And so therefore, his consumption of calories is low. And at the same time, his resting energy expenditure is increasing from 12 to 20%. So that is the negative balance that he maintains. And then along with that is the retention of middle molecules and uremic compounds with declining GFR. Then metabolic acidosis ensues, and there is accelerated protein catabolism leading to loss of lean mass. Then increased inflammation, which causes increased acute phase reactant protein, leading to reduced protein synthesis, leading to hypoalbuminemia. And along with this is intercurrent illness. So everything, leads to increased morbidity and mortality. Now, the patient gets on to dialysis. Now, the dialysis procedure itself is catabolic. There's loss of blood and nutrients in the dialysate, and therefore, and some patients do have inadequate dialysis dose. So all these things put together, they cause malnutrition in CKD patients. Above all, there's impaired clearance of pro-inflammatory cytokines because of impaired renal function. There's fluid overload, renal replacement therapy, then metabolic acidosis, superimposed illness, accumulation of uremic toxins, which all lead to increased levels of pro-inflammatory cytokines. That is, CKD is a mildly inflammatory state. And then there is increased resting expenditure, reduced appetite, reduced energy intake, reduced physical activity, cellular senescence, then mitochondrial dysfunction, then impaired DNA, testosterone deficiency, vitamin D deficiency, impaired signaling of insulin and IGF-1. We'll be seeing all these things. And these all lead to physical frailty. So if you have a look at this figure is showing you the stages of kidney disease and the prevalence of protein energy wasting in kidney disease. So between stage CKD, stage 2 and 4, the prevalence of protein energy wasting is 18 to 48%. And when the patient reaches ESRD, then about 75% of the patients are already malnourished. And as the CKD stage increases, the appetite worsens. Now, here, if you have a look at this figure is showing you that the creatinine clearance, as long as it is above 50 ml per minute, the protein intake is about 1 gram per kg body weight per day. But as you can see that as creatinine clearance is reducing, the protein intake is declining from 0.1 to eventually 0.54 and even more. So protein energy wasting most likely sets in during CKD stage 3 or even earlier, partially due to inadequate nutritional management in pre-dialysis phase, and becomes clinically evident when GFR declines below 15 or 10 ml per minute. Now, the MDRD study has shown that there is an association between serum albumin and the GFR. Serum albumin level decrease, indicating a decline in circulating protein levels or serum protein concentration due to protein losses or inflammation as GFR declines below 60 ml per minute. Now, if you have a look at this table is showing you the CKD registry of India, which is showing you that with increasing CKD stage, the BMI decreases. So when the GFR is above 90, that is CKD stage 1, the BMI is close to 27. And as the GFR is declining and the CKD stage is increasing, say, for example, CKD stage 5, the BMI has come down from 27 to 21 or 22. So the catabolic pathway, which causes protein loss, is here on this in this figure. This causes muscle wasting, decline in nutritional status, and CKD. So what is happening here is that CKD and uremia, they cause reduced dietary amino acid intake. So there is a small amino acid pool inside the body for protein synthesis. Along with this, there's a reduction in ghrelin, increased levels of leptin, then vitamin D levels are decreased, then IGF-1 axis is impaired, and the growth hormone secretion is reduced. And along with that, the inflammatory cytokines are increased, the angiotensin 2 is high, the insulin sensitivity decreases, aldosterone is high, the cortisol levels go up, and because of that, the insulin resistance is increased. And all these things put together, they cause protein breakdown, because as it is, the protein synthesis is low because the amino acid availability is low, and protein breakdown is all because of these cytokines and catabolic processes. Now, when the patient gets on to hemodialysis, we know that hemodialysis stimulates muscle and whole body protein loss and alters substrate oxidation. This is an elegant experiment by Kaiser, who measured the protein synthesis and degradation of patients on maintenance hemodialysis. Before, that is pre-dialysis, then during dialysis, and 2 hours after completing the dialysis session. And he concluded that hemodialysis is a catabolic process because proteolysis is minimum during dialysis. So a patient on dialysis, he loses nutrients and water-soluble vitamins during dialysis. And then on top of that, the causes of inflammation are incompatible dialysis membrane, heparin, use of heparin, endotoxins, and blood loss sequestered in hemodialysis tubing. So he concluded that there's a threefold increase in forearm loss of protein during hemodialysis. The net result is increased net whole body protein loss, that is about 96%, and net forearm protein loss, that is about 164%. The branch chain amino acid decrease in this experiment to 31%, essential amino acids decreased to 33%, non-essential amino acids declined to 38%, and total amino acid decreased to 36%. So whole body protein breakdown continued to be elevated by 11% during the 2-hour period after dialysis, even after giving meals, suggesting that a process causing protein loss is initiated by the therapy, that is the dialysis itself, and that persists. And to tell you the truth, this catabolic process continues post 24 hours after dialysis. So increasing dietary protein intake alone will not eliminate CKD-stimulated protein loss until the catabolic mechanism is blocked, that is inflammation. So as I mentioned, hemodialysis is associated with an acute phase response due to prosthetic vascular access, bioincompatible membranes, acetodialysate buffer, bacterial fragments in the dialysate, and endotoxin originating from the dialysis water supply. And we know that CKD is characterized by a persistent low-grade inflammation. And chronic inflammation is a major culprit in muscle wasting in our patients. The CRIC study has shown that high circulating levels of C-reactive protein predict all-cause mortality, especially in patients with hypoalbuminemia, which reflects impact of inflammation on albumin synthesis, that is poor nutritional status. And here you can see that this graph is showing you muscle wasting in our patients. Now, inflammation is linked to anorexia. Cytokines inhibit feeding through both peripheral and brain mechanisms. The higher level, as the CRP levels and the IL-6 levels increase, the appetite worsens and the patient is not able to eat well. And then anorexia is therefore linked to weight loss and muscle loss, because with the worsening of appetite, it causes loss of lean mass, hand grip strength, then body fat, and some of skin folds. So early intervention to control inflammation can check malnutrition. And how do you do, in a simple way, how do you correct inflammation? The simplest way, we are not using drugs to do that. At least the inexpensive approach is to modify physical activity in these patients and bring about dietary supplementation with high fiber probiotics. So the study has shown that 6 months of regular walking exercise, that is 30 minutes per day for 5 days per week, exerted an anti-inflammatory effects by reducing the ratio of plasma IL-6 to IL-10 levels and a downregulation of T lymphocyte and monocyte activation. Now, what does metabolic acidosis do? Metabolic acidosis plays an important role in the pathogenesis of nutritional abnormalities associated with uremia by activating branch chain keto acid dehydrogenate. It increases activity of caspase-3 and the ATP-dependent ubiquitin proteasome pathway system, which is the most important major mechanism for protein breakdown or muscle breakdown in our patients. Then it also causes insulin resistance, inflammation. All this leads to increased muscle breakdown and decreased muscle protein synthesis, decreased albumin synthesis, and finally, protein energy wasting. So therefore, one has to correct metabolic acidosis to reduce protein catabolism. Here you can see by supplementing soda bicarbonate, you can actually improve the metabolic acidosis or correct it and improve this SGS score, the nutritional status of the patient. So one has to maintain serum bicarbonate levels at more than 22 mmol per liter, and it should be evaluated every month, though we do not do here in the practice. And also, this is again another study which is showing you that chronic metabolic acidosis has to be controlled. So to summarize whatever I have said so far, once chronic kidney disease sets in, vicious cycle of catabolism caused by uremia, induced anorexia, inflammation, metabolic acidosis, malnutrition, frailty, depression, infection, anemia, fluid imbalance, hormonal imbalance begins, which leads to loss of lean mass. And therefore, surveillance of nutritional status is required for good outcome. Otherwise, our patients do have a poor quality of life. Now, undernutrition causes muscle protein loss and is the key contributor to the development of sarcopenia and frailty in CKD, which affects nutritional status. Now, deterioration of clinical nutritional status is characterized by progressive weight loss, wasting of fat and skeletal muscle tissues, and reduction of serum proteins. So in kidney failure, why do we need to modify diet? It is because in kidney failure, nutritional therapy allows good control of several consequences of the disease like nausea, vomiting, all the uremic symptoms, anorexia, and it can even help in delaying the initiation of dialysis. So objectives of nutritional intervention in CKD are address the root cause of CKD, that is diabetes, hypertension, and obesity, decrease proteinuria, achieve and maintain optimal nutritional status and nitrogen balance to prevent malnutrition and muscle wasting, fatigue, nausea, shortness of breath, with optimization of fluid intake and poor quality of life. Now, prevent buildup of toxic metabolic products, thus minimizing the risk of uremia, and of course, then the cardiovascular disease, and avoid complications such as hyperphosphatemia to reduce the risk of secondary hyperparathyroidism, anemia, hyperkalemia, hypovolemia, metabolic acidosis, heart failure, and hypertension. So the aim of nutritional therapy is to retard progression of disease. Now, pathophysiology of CKD necessitates both the pharmacological and nutritional intervention. Now, the initial pathophysiology of CKD involves two mechanisms: initial mechanism of the specific underlying etiology and a series of progressive mechanisms involving hyperfiltration and hypertrophy of remaining viable nephrons due to a long-term decrease in renal mass. So two factors explain progression of CKD, the hemodynamic and the non-hemodynamic factors. Now, because of the paucity of time, I will not be going into the details of this because this is beyond the scope of my talk here today. I'm going to give you a bit of theory and most of practice. Now, protein energy wasting is amongst the strongest predictor of mortality in CKD patients. Based on ISRNM classification, prevalence of protein energy wasting increases as renal function declines from less than 2% in CKD stages 1 to 2 to 11 to 54% in CKD stages 3 to 5. In patients undergoing maintenance dialysis, as I had shown you earlier on, the prevalence of protein energy wasting can go up to 75 to 78%. Now, mortality is in CKD is related to loss of muscle mass. This association leads us to two important questions. One, how are the protein stores lost? And two, how can the losses be prevented? So the loss of muscle protein stores results from three responses. One, impaired growth of new muscle fibers. Two, suppression of protein synthesis. And three, stimulation of protein degradation. So I will not go into the details of these mechanisms because this is beyond the scope of my talk today. However, you can see there is slow muscle regeneration in our CKD patients, and there's increased collagen deposition and leading to fibrosis, and increased TGF-beta1, which causes fibrosis. So I'll skip this also. And here, this is the third major mechanism that degrades proteins in muscles, the ubiquitin proteasome system, which you should be knowing very well. And this is the winner of 2004 Nobel Prizes, such a wonderful revelation to the world. Now, how can the loss of muscle mass be prevented? So now I'm going to talk about intervention and practice. In order to optimize the response of any specific drug therapy for muscle wasting disease, it is important to first diagnose and stabilize the clinical condition of the patient, provide adequate nutrition, provide an adequate level of exercise when the patient is stabilized, and control inflammation. So inflammation is the main culprit. Inflammation and oxidative stress are the two main culprits in our patients. So chronic kidney disease requires adaptation to lifestyle, adaptation to a new situation, whether good or bad. It involves acceptance. To achieve good health goals, behavioral changes are the prerequisite. So the three most widely studied interventions, or you can call them as modifiable characteristics, linked in their effect on GFR for slowing progression of CKD are lowering of blood pressure, proteinuria reduction, and antihypertensive drugs. Now, in 1984, this prospective randomized trial of early dietary protein restriction in chronic renal failure was published. And Rossmann in this study showed that if patients adhere to diets containing 0.4 to 0.6 grams of protein per kg body weight per day, the rate of progression of chronic renal insufficiency is reduced. Moderate protein restriction introduced early slows down the progression of chronic renal failure or even halts its course. Renal disease therefore benefits most from early protein restriction. And here we can see that the median serum urea of patients followed for up to 18 months in this case, these serum urea levels were low in protein restricted groups. So in early CKD stages, renal-specific diet helps protect kidneys from further damage, and current guidelines for CKD management recommend dietary and lifestyle modifications. So what are specific nutritional requirements of CKD patients? Now, I have already said that this in the beginning, the diet of a CKD patient should help correct signs and symptoms of complications of chronic renal failure, reduce uremic toxicity, decrease proteinuria, maintain good nutritional status, low risk of kidney disease-related secondary complications like cardiovascular disease and hypertension, slow the rate of progression of kidney failure to ESRD, delay initiation of dialysis. So the issues which need to be addressed in a CKD patients are control of uremic symptoms like nausea, vomiting, giddiness, and low appetite, preservation of nutritional status, prevention of protein energy wasting, controlling comorbidities like hyperkalemia, hyperphosphatemia, hypertension, diabetes. I mean, controlling blood pressure and glucose, blood glucose, then volume overload with fluid and salt restriction, proper hydration in pre-dialysis conditions, state, that is CKD stage 1 to 4, so that the patient is hydrated optimally so as not to go into hypertension or to cause further damage to the renal to the kidneys. Then metabolic acidosis, inflammation, oxidative stress, formation of uremic toxins, and irregular bowel movements. Now let's have a look at the effect of dietary protein on renal hemodynamics. So shall we advise on low protein or normal protein or high protein? Now, the debate has been continuing on dietary protein restriction in CKD. Kidneys play a crucial role in amino acid and protein metabolism, including breakdown and excretion of protein metabolites. Dietary protein intake not only impacts metabolic processes regulated by kidney, but also on kidney function itself. So excessive protein intake when nephron mass is reduced causes damage to remaining nephrons, increase in single nephron GFR, increased glomerular capillary and transcapillary pressure after renal mass reduction is the cause of accelerated glomerular injury. Now, dietary protein, we know, causes postprandial hyperfiltration, induces or increases proteinuria, and leads to glomerulosclerosis and renal insufficiency. So low protein diet has independent therapeutic effect. Low protein intake lowers hyperfiltration and retards onset of proteinuria and glomerular fibrosis. Now, if you have a look at this figure is showing you that low protein diet causes vasoconstriction of afferent arterioles and vasodilation of efferent arterioles, thereby reducing intraglomerular hypertension and preventing decline in renal function through angiotensin modulation. And along with this, if you add a low salt diet, you have much better results. So low protein diet has a lot of beneficial effects, like it reduces postprandial glomerular hyperfiltration, proteinuria, uremic toxins, oxidative stress, metabolic acidosis, phosphorus and PTH. It reduces insulin resistance, blood pressure, and you have a much better control of uremia and can delay initiation of dialysis as well. However, the risks are also umpteen. You have the patient maybe getting inadequate calorie intake, which will cause protein loss and hypercatabolism, inflammation, worsening of acidemia, and altered glucose homeostasis, eventually leading to protein energy wasting. That is what we're talking about. We're trying to prevent protein energy wasting in our patients, and so the clinical outcome can be even worse. Now, it was in 1996 that another study appeared, which is the largest study in nephrology here, which is the effect of dietary protein restriction on the progression of advanced renal disease in modification of diet in renal disease study, that is the MDRD study. Now, this was an intervention study which was conducted in, I think, 15 different centers. This was a comparison of a low protein diet, that is 0.58 grams per kg body weight per day of protein, with very low protein diet, that is 0.28 grams per kg body weight per day of protein, supplemented with essential amino acids or essential keto analog amino acids of 0.28 grams per kg body weight per day. And the study found that among patients with moderate renal insufficiency, the slower decline in renal function that started 4 months after the introduction of a low protein diet suggests a small benefit of this dietary intervention. Among patients with more severe renal insufficiency, a very low protein diet as compared with a low protein diet did not significantly slow the progression of renal disease. So MDRD study actually consisted of 2 concurrent randomized multicentric clinical trials to evaluate 1, the effect of dietary protein restriction, and 2, blood pressure control in patients with renal diseases of diverse etiology. Yes, there were 15 participating clinical centers. And it was seen that patients who were kept on very low protein diet, there was 82% greater risk of all-cause mortality in these patients. And these figures are showing you the protein intake during follow-up of low protein diet, that is 0.58 grams, then a very low protein diet, that is 0.28 grams, and very low protein diet, that is 0.56 grams, again, from foods and supplements. So here you can see the relationship of GFR to protein intake. And so the study concluded that in patients with moderate renal disease, there was a faster mean decline in GFR during the first 4 months after randomization, but a slower mean decline thereafter in patients who were prescribed a low protein diet compared with the usual protein diet, but no significant difference in the level of GFR at 3 years of follow-up was observed. A longer follow-up was required to demonstrate a beneficial effect of this intervention in patients with moderate renal disease. This suggests a beneficial effect of a low protein diet on the progression of renal disease in patients with advanced renal insufficiency. Now, this is the same graph, again, a relationship of a GFR decline to protein intake. However, what I'm going to tell you is very, very important. The study has shown the decrease in protein intake of 0.2 grams per kg body weight per day was associated with a slower mean GFR decline by 1.15 ml per minute. That is 29% of the mean GFR decline. If the GFR decline is extrapolated until renal failure, until the patient really goes into ESRD, a patient with 29% slower GFR decline would experience a 41% prolongation of time to renal failure. So the actual prolongation would depend on the initial GFR. So MDRD study recommends a target for prescribed dietary protein of 0.6 grams per kg body weight per day. This is what we've been practicing ever since. But now, since the new KDOKI guidelines update has come, which now says 0.55 to 0.6, otherwise we were practicing 0.6, with 0.35 grams per kg body weight per day as high biological value protein. Now, Then another study has appeared on plant-dominant low-protein diet for conservative management of chronic kidney disease, and the clinical research trials are going on. This is called Play-Doh diet, the plant-dominant low-protein diet, in which the patient is prescribed 0.6 to 0.8 grams of plant-based diet, and out of this, at least more than 50% of the protein is from the plant source. And in this study, they have recommended sodium intake of less than 4 grams per day. However, if the patient has edema or hypertension, then less than 3 grams per day of sodium. High fiber intake of 25 grams, naturally, because you're taking so many plants. So it's almost a plant-based diet. So you have a high fiber intake and adequate energy of 30 to 35 kilocalories, which is difficult to achieve. So the benefits of this low-protein diet, with at least more than 50% of plant source of protein, the beneficial effect is that it causes lowering of intraglomerular pressure. There's synergistic effect with RAS inhibitors and SGLT2 inhibitors. It's it better controls uremia and delays dialysis. There's prevention of cardiovascular harms of meat, that is non-vegetarian diet, and less absorbable phosphorus because humans do not express the enzyme called phytase. So therefore, absorption of plant-based phosphorus is only 40 to 50%. Then lowers acid load, that is less acidogenicity, then high dietary fiber enhancing GI motility and favorable microbiome, so less of uremic toxins and less of cardiovascular disease. However, the risks of or the potential challenges in this diet are the risk of protein energy wasting, that's what we're talking about, and inadequate essential amino acid intake in these patients, and high potassium load, that is hyperkalemia. And what are we aiming for? To prevent hyperkalemia, to prevent hyperphosphatemia, and this is what this diet is actually giving you in plenty. Now, after this diet, this was published in 2020. Before this publication, another study came up, which was a prospective randomized controlled trial on keto analog supplemented purely vegetarian, very low protein diet. So MDRD study, just try to recall that they were giving very low protein diet, that is 0.28 grams per kg body weight per day of protein, but they did not specify that it was vegetarian. But here is a step ahead of that diet, that is keto analog supplemented with vegetarian, very low protein diet and CKD progression. So what they have done is they've given 0.3 grams per kg body weight of vegetable protein. Along with that, they've given 1 capsule of or 1 tablet of keto analogs per 5 kilograms body weight per day, which means that there's going to be a lot of pill burden, about 9 to 12 tablets will have to be given to the patient, and it was compared with low protein diet, that is 0.6 grams per kg body weight per day for 15 months. And the results were good. So the primary end point, that is renal replacement therapy, initiation of 50% reduction in the initial eGFR was lower in the vegetarian, very low protein keto analog group compared to the normal diet. And also the GFR increase in the vegetarian keto analog supplemented group. The serum bicarbonate increased so that the metabolic acidosis was very well controlled. The serum calcium levels increased and the phosphate levels decreased. Therefore, hyperphosphatemia was also controlled in this merit. But the demerit of this diet is pill burden. 10 to 12 capsules of keto analogs will have to be taken every day. So now at this point, we have 3 different choices of diet which one to prescribe. Conventional low protein diet, that is 0.55 to 0.6 grams per kg body weight per day, or you want to prescribe very low protein diet, that is VLP, that is 0.3 to 0.4 grams per kg body weight per day with keto analogs and give them a lot of pill burden, and practically vegetarian diet supplemented with keto analogs. So you have 3 options. Now, however, restriction of protein in low protein diet and encouraging plant protein up to 50% can be challenging for an already nutritionally compromised patient population of CKD, as malnutrition is an important concern. So here, even the source of protein has an independent therapeutic effect, as Liliana Garnieta has shown. Plant protein is preferred over animal protein because there's 20% less proteinuria in soya-based diet, and fibrosis is lowest in soya group compared to the casein group, and reduced medical animal protein intake reduces glomerular hypertension. So if you have a look at this figure showing you that when you give an animal protein load, there's increase in the GFR and renal plasma flow compared to when you give a soya-based protein load. And this is a study on red meat versus plant meat. There's a strong dose-dependent positive association of red meat as risk factor for ESRD. Okay, and non-meat protein, we know, just as you have in the DASH diet or DASH trials, has a beneficial effect on blood pressure, but we're not going to discuss about this. So vegetarian diet in chronic kidney disease, a friend or a foe? Vegetarian diet is a natural source of prebiotic. Vegetarian diet might potentially reduce urinary toxins like indoxyl sulfate and precursor sulfate. And of course, there will be low serum urea, and the serum phosphate levels will be low in such diets. Now, this is a typical DASH diet in the Mediterranean diet. Mediterranean diet is rich in olive oil and fish and poultry, and low-fat dairy products, and plenty of fruits, vegetables, bread, cereals, nuts, seeds. Nuts and seeds are, in plenty. But can our patients afford this diet? This diet, the DASH diet and the Mediterranean diet, are known to reduce risk for hypertension and cardiovascular disease and metabolic syndrome. For CKD patients, one has to recommend use of low potassium vegetables, fruits within the constraints of biochemical markers, olive oil, and eggs and fish. But high potassium intake increases risk for hyperkalemia in patients with CKD, and the current recommendations and guidelines severely restrict dietary potassium in patients with CKD. So DASH diet and Mediterranean diet are out of question for our patients. However, this is the Ckd latest update on clinical practical guidelines for nutrition in CKD. So what is the typical diet of a pre-dialysis CKD patient? We want to give the patient a balanced diet, which is low in protein, low in salt, fat, potassium, and phosphorus, but high in fiber and high in energy. So this table summarizes the nutrient requirement for our patients in pre-dialysis stages 2 to 5 non-dialysis. So I've already discussed very low protein diet. If you want to give very low protein diet, you have to give 1 keto analog tablet per 5 kilograms. But if you want to give a normal protein diet, that is 0.55 grams per kg body weight per day of protein, then you give 1 tablet per 10 kilograms of body weight. So you can reduce the pill burden, but at the same time prevent uremic symptoms. The patient can have a better control of blood pressure, metabolic acidosis, hypertriglyceridemia, and much better control of insulin sensitivity. Everything will be really perfect and fine. But remember, and the time to initiation of dialysis will be low, and of course it will lower the phosphates also. But remember, it is contraindicated in case the patient has hypercalcemia, and remember that these are calcium-based salts, so the patient can go into hypercalcemia. So you have to keep checking the calcium, the serum calcium of the patient. And also if the patient has uncontrolled hypertension, you should not advise this diet. Now, low protein diet is the normal diet that you prescribe every day to your patient in the OPD. That is 0.5 to 0.6 grams per kg body weight per day. And at least 50% of protein should be of high biological value. And if the patient is diabetic, then you start the patient at 0.8 grams per kg body weight per day. And as GFR declines, you bring down the patient protein intake to 0.6 grams. And of course, energy intake has to be low in diabetics, that is 25 to 30 kilocalories per kg body weight per day. Now, in case of acute illness, whether diabetic or non-diabetic, the patient is going into hypercatabolism. So you have to increase the protein intake to 1 gram per kg body weight per day. Now, energy intake in CKD patients should be 30 kilocalories if the patient is above 60 years of age, because these patients tend to be more sedentary, and 35 kilocalories if the patient is less than 60 years of age. Well, you have to restrict fat because the patients are at risk of developing cardiovascular disease, and the patients do die of cardiovascular disease. They don't die of the kidney disease per se, but actually they die of the cardiovascular disease. So visible fat has to be low, which is about, if you see the recommendation, fat intake should be 30% of total kilocalories. But here in our patients, you have to bring it down to 50 to 20 grams per day and nothing beyond that, simply because otherwise, the patient will go into hypercholesterolemia and all those things. So what is the best combination of oil that you should recommend to your patient. You should tell the patient to use peanut oil for one dish and mustard oil for the second dish, and similarly peanut oil for one, or rice bran oil or sunflower for another dish. So you should try and educate patients to use combination of oils so that they get complete dosage of fatty acids. And saturated fatty acids should be reduced to 7%, less than 7% of the total calories, and PUFA to less than 10%, and MUFA to between 10 to 15%. Now, dietary cholesterol has to be reduced to or restricted to 200 milligrams daily. Right, and you can also supplement omega-3 fatty acids. Though earlier on recommendations were that for IU nephropathy, if the proteinuria is not coming under control with ACE inhibitors and ARBs, even after 6 months of prescription, then omega-3 fatty acids can be used. But I think this concept has faded out. But however, you can always prescribe omega-3 fatty acids to your patients because these are cardioprotective. Sodium intake should be less than 2.4 grams. But if the patient has hypertension or is edematous or has uncontrolled hypertension, then according to JNC, should bring it down to 1.5 grams per day. Potassium, as long as the potassium is within the limits, you needn't really have a very tight control of what the patient is eating. But if the potassium is more than 5, or the patient is on the potassium sparing medication, then you have to restrict potassium to less than 1 milliequal per kg body weight per day. Or if the urine output is low, then you have to restrict potassium intake to less than 1 milliequal per kg body weight per day. And the patient will have to avoid high potassium fruits and vegetables. Now, calcium intake is recommended is less than 2 grams or less than 2,000 milligrams, preferably between 1,200 to 1,500 milligrams per day, especially if the patient is on vitamin D analogs. And phosphorus intake should be restricted between 800 to 1,000 milligrams per day. Remember that anemia cannot be corrected with diet. I'll be coming to it later on. Now, hyperkalemia is a known complication with RAS blockade and occurs in about 10% of our patients and up to 38% in hospitalized patients. So whenever you initiate ACE inhibitors or ARBs, you have to monitor serum creatinine and the potassium as well. If the patient is going into hyperkalemia, then restrict potassium to less than 1 milliequal per kg body weight per day. Stop green vegetables and fruits, which are high in potassium, and you may have to use GI cation exchanger for bringing potassium down. So what is, you remember that 1 gram of protein brings you 1 milliequal of potassium. So you know that if your patient is taking 50 grams of protein, he's taking 50 milliequals of potassium, and you can't go beyond that in any case. So prescribe fruits and vegetables which are low in foods. And how much fruit can you prescribe in a day? It is approximately 50 grams of fruit that you can prescribe in a day. That is one small apple. So you should say that one small apple is enough for you. Okay, and the fruits which our patients can take are apple, banana, guava, pear, papaya, and pineapple, because these are all low in potassium. Low in potassium means, see, there are 3 categories: low potassium, moderate potassium, and high potassium. A potassium count which is less than 100 milligrams per 100 grams of the food is low. Anything between 100 milligrams to above 100 milligrams to less than 200 milligrams is moderate, and anything above 200 milligrams is high. So like Musami and Malta and citrus fruits, they are very high in potassium. Pomegranate, for example, they have about 300 to 400 milligrams of potassium per 100 grams. So you cannot advise them this kind of a food. You have to restrict green leafy vegetables, tomatoes, sweet lime, lemon, carrots, raw salad, mango, dry fruits, fruit juices, watermelon, vegetable soups, coconut water. And you may have to advise the patient to reduce potassium content of the vegetables by leaching or removing potassium from vegetables by boiling or soaking chopped vegetables in lukewarm water for half an hour. Now, Ckd update recommends maintaining serum albumin level at more than 4 grams per deciliter and free albumin at more than 30 milligrams per deciliter. And 50% of protein should be from high biological high biological value. So you can prescribe milk, cottage cheese, eggs, fish, yogurt, lentil, and soy products to your patient. And these are the foods of high biological values like milk and milk products, paneer, then you have soya products, then you have fish, chicken, and egg. Egg white is a very good friend of your patients. So do advise them egg whites because it's got very low protein to phosphorus ratio. It's devoid of cholesterol. Now, proteinuria is an early and sensitive marker of kidney damage. So, you know that combination of ACE inhibitors and low protein has an independent therapeutic effect. ACE inhibitors and ARBs reduce degree of proteinuria and renal disease. Low protein diet when combined with ACE inhibitors has additional antiproteinuric effect. This has been observed that if enalapril 20 milligrams per day reduces proteinuria by 20%, then by adding a low protein diet, it reduces, the combined effect is reduction in proteinuria by 30%. So that is really good. But remember that low protein diet will have to be supplemented with calorie dense and low protein supplements. This is our group. This is a study from our department that what we did was we gave a low protein diet to our patients. Along with that, keto analogs were supplemented, and we found that there was a slower decline in GFR amongst our patients. I followed these patients up for up to 70 months, and this work I presented at ASN also and at EDTN. They were they were very well appreciated. And there was a faster decline in the GFR in controls. And the transition from one stage into another was slower in the treatment group compared to the controls. Here we can see. Okay. And so the faster decline in renal function to ESRD in controls was seen compared to the treatment group. So when you combine keto analogs with very low protein diet, so by the end of the study, there's reduction in proteinuria, there's correction of metabolic acidosis, it lowers serum phosphate levels, the insulin sensitivity increases, the HDL increases, and the triglycerides come down. So there's a lot of benefit of giving keto analogs. This should be supplemented. The blood pressure control and the sugar control is much better. I have seen it in my own clinical trial that it was, we had fantastic results. Now, a second camp in the field of renal nutrition opines that even a protein intake of 0.6 grams per kg body weight per day needs to be supplemented by essential amino acids or keto analogs, because that helps in reducing decline in the eGFR. So these are new things which are coming up. So you should actually start practicing using keto analogs. Now, serum albumin levels in adults with CKD stage 5D on MHD may be used as a predictor of hospitalization and mortality with lower levels of associated with higher risk. So actually serum albumin we use as a marker of nutritional status, but actually it is not a marker of nutritional status because it's an acute phase reactant protein. So inflammation or injury or any trauma, it will immediately come down, even in a healthy person. So it is actually a predictor of hospitalization and mortality. Now, there is a quantitative association between decreased GFR and cardiovascular risk. Patients with moderate to decreased renal function have 2 to 4-fold increase in risk of cardiovascular disease in comparison with individuals who are not CKD. The risk increases to 4 to 10-fold in stage 4 and to 10 to 50-fold in stage 5 in renal failure. And lipid lowering appears useful in patients with advanced CKD. So substitute saturated fats with grains and unsaturated fatty acids with fish, vegetables, legumes, and nuts. And here, this figure is showing you the independent components of chronic kidney disease as cardiovascular risk state. And these are showing you the GFR and the relationship with microalbuminuria, anemia, etc. The OmniHeart study has shown that carbohydrates, if they are partially replaced by unsaturated fats, predominantly monounsaturated fats, it lowers blood pressure, triglycerides, and increases HDL cholesterol. So monounsaturated fatty acids are, in Indian scenario, it is the mustard oil or the olive oil. So olive oil is expensive, so you can advise your patients to take more of mustard oil than anything else. Now, a component of diet which reduces dyslipidemia are plant sterols, which are, and the source is soybean butter or margarine. And this also improves glycemic control. So one has to restrict full fat dairy products. You have to tell them milk without cream and tropical oils. And Include soluble fiber in the diet to reduce total LDL cholesterol, because for every 1 gram increase in soluble fiber, there's a decrease in the LDL cholesterol by an average of 2.2 milligrams per deciliter. But remember, boys and girls, that we have problems with patient getting into hyperphosphatemia and hyperkalemia. So because of that, the fiber content of the diet for a CKD patient is really low. So you have to ask a dietitian how to increase the fiber in the diet. So the recommendation is that at least 25 grams of fiber should be given to the patient through grains, vegetables, fruits, legumes, and nuts. Soluble fiber is high in barley. You can give barley, oat, beans, and lentils, apples, or oranges, yes, nuts and flax seeds, beans and dried peas, cucumber, and celery. The step 1 and step 2 diets are widely recommended as the first line of CV intervention and lower blood pressure, and they also lower blood cholesterol levels. So reduce sugar and refined carbohydrates and prefer low-fat, restricted carbohydrate diet. Say big no-no to the bakery products and stop your reuse of oils used for frying. Restrict eating out in restaurants. Now, anemia cannot be corrected through diet because everything which is rich in iron, you tell the patient not to eat, like spinach. So correct iron profile, supplement patients with vitamin B12, folic acid, iron, EPO, which you do. Now, patients with advanced CKD are advocated to follow strict dietary restriction to prevent hyperkalemia, which limits consumption of potassium-rich foods such as fruits, vegetables, high fiber-containing foods to prevent hyperphosphatemia. And on top of that, we give them plenty of antibiotics. So all these things put together cause they increase dysbiosis of gut microbiome, and therefore to improve gut microbiome, one has to stick to a more of a plant-based pulses and fiber-based diet. Here you can see this figure showing you the reduction in uremic toxins on introducing insoluble fiber in the diet. Now, I presented late-breaking this randomized clinical trial at late-breaking clinical trials at ASN Renal Week 2020. In this, we supplemented our patients with enzymbiotics, that is probiotics, symbiotics, and proteolytic enzymes, and we found that the uremic toxins decreased considerably in our patients. The indoxyl sulfate and precresol levels decreased, and the quality of life improved in our patients. That was a very good study. So, and even there's a study which was published in 1907 that Bulgarian peasants have unusual longevity. Why? Because they consume large quantity of fermented milk products. So one can think of introducing fermented products, like you can prescribe dose cyanidly to your patients, tempeh, onion, garlic, yogurt, pickled cucumber, or kefir, which is a fermented milk beverage, cottage cheese, and kimchi. These are all you can prescribe to your patients. Now, JNC7 report, European Society of Cardiology, European Society of Hypertension, they all recommend non-pharmacological interventions such as diet, weight loss, and physical activity for the primary and secondary prevention of hypertension. If you have a look at this figure is showing you that, there's a linear dose-dependent response for the changes in sodium intake. So as you increase sodium intake, the blood pressure goes up, and the salt-resistant hypertensive patients require addition of drug therapy to control their blood pressure. However, when you reduce sodium intake, there is reduction in systolic and the diastolic blood pressure after quite a long time, but definitely there is a response. So sodium, I've already said that you have to prescribe less than 2.4 or up to 1.5 grams of sodium you can prescribe. And how do you measure this? This is important. Take 1 teaspoon of salt and level it. When you level it, that is 5 grams of sodium chloride. That's what you can tell your patient. The easiest way of telling your patient how much sodium to be given to your patient. And of course, one has to avoid canned foods, fruits, pickles, fruit jams, because these all contain salt as preservative. And in CKD patients, proteinuria is the strongest correlate of arterial hypertension and particularly of increased nocturnal blood pressure, possibly as an expansion of vascular damage. So one has to restrict salt because salt is directly related to the degree of proteinuria. A meta-analysis estimated that even a modest reduction in sodium intake of 1 gram per day reduces systolic blood pressure by 3.1 millimeters of mercury in hypertensive patients and 1.6 millimeters in normotensive patients. So now moving on to the dialysis patients, what are the nutritional interventions and the goals for dialysis patients? The nutritional problems in adult patients with CKD stage 5 CKD on dialysis can be classified into three categories: protein energy wasting, obesity, and diabetes. Now, protein energy wasting is an independent determinant of morbidity and mortality in hemodialysis and the PD patients. So if malnutrition is present at any station of dialysis, it is a very strong predictor of subsequent increase in the relative risk of death. You can see the relative risk of death is very high in malnourished patients compared to the patients who have normal nutritional status. So, and from metabolic point of view, each dialysis session decreases plasma amino acid levels and as a consequence blunts intracellular protein synthesis. So a patient on hemodialysis loses 10 to 12 grams of amino acids and 1 to 3 grams of protein on every session, and a patient on PD loses 2.3 to 3.5 grams of amino acids and 5 to 15 grams of protein in PD in 24 hours. And the losses are higher when the patient has peritonitis. They can go up to 15 grams or even higher. Now, the Canusa study has shown there's a relative risk of death increases with lower serum albumin and worse nutritional status as assessed by SGA and percent lean body mass. So for every 1 gram lower serum albumin concentration is associated with 6% increase in relative risk of death. And for every 1 unit lower score of SGA, this is associated with a 25% increase in relative risk of death. So issues which need to be addressed in hemodialysis, in patients on maintenance dialysis are volume overload, fluid restriction, sodium restriction, and hyperphosphatemia. So talking about fluid balance, we have to prevent interdialytic weight gain. So fluid volume and hemodynamic management in hemodialysis patients is an essential component of dialysis adequacy. Restoring salt and water homeostasis in hemodialysis patients and achieving dry weight is a nephrologist's target of ESRD management. So we are talking about this phase, the interdialytic phase, where the patient is undergoing chronic hemodynamic stress because of fluid overload, hypervolemia, hypertension, congestive injury, and cardiac remodeling. So the greater interdialytic weight gain is associated with poor all-cause and cardiovascular survival in hemodialysis patients. The interdialytic weight gain is a function of oral fluid intake that includes routine food ingestion, mortality, predictability of high fluid gain holds independent or other outcome predictors such as nutritional status. Optimal management of fluid and sodium imbalance in dialysis patients consists of adjusting salt and fluid removal. So this study has shown that increased dietary sodium is independently associated with greater mortality among hemodialysis patients. So you require to do more of UF if the patient is taking a higher sodium intake. And here you can see that a higher interdialytic weight gain is associated with higher death risk. So adhering to fluid restriction, mind you, is one of the most difficult aspects of the hemodialysis treatment regime. And you know your patients are non-compliant. So you have to educate patient on fluid goals. Fluid prescription should be previous 24 hours urine output plus 500 ml. However, if the patient is a really edematous, then you would bring down this plus 500 ml to even a lower amount. So this figure is also showing you greater fluid retention is associated with poor survival across different HD patient groups. So fluid management, actually, it should, if the patient is hospitalized, then you have to take into consideration the oral intake, the IV infusion, and the urine output charting. So fluid intake includes water taken with meals, medications, or otherwise, tea, coffee, milk, curd, or any other liquid or beverages. And the fluid prescription, as I said, is 24-hour previous urine output plus 500 ml if the patient is dry. But if the patient is not dry, then you have to reduce it to, this is your judgment. So replace fluids. The way out for restoring fluid balance in patients who are cheating on drinking water, you have to replace fluids with solid foods, for example, milk, more of cheese, okay, because these are solids. Amount of tea can be reduced to once a day. And here, this is the figure which is showing you, you can cut this, give them soya nuggets, give them tofu, give them paneer, give them solid chicken. And the patient on hemodialysis can always take chicken and fish. So that's not a problem at all. And of course, telephonic counseling by nephrologists and dietitians will bring it down, and sips of water can be taken to prevent dryness of mouth. I've already spoken about this. I will not talk about this. Yeah. So what is the nutrient prescription for hemodialysis and petroleum dialysis patients? For hemodialysis, the latest guidelines say 1 gram. Earlier on, it was 1.2 grams per kg body weight per day, but now it has come down to 1 gram. And then for petroleum dialysis, it is 1.2 to 1.3 grams per kg body weight per day. If the patient has peritonitis, then increase protein intake to 1.5 grams per kg body weight per day. And if the patient is on petroleum dialysis, then you have to include the energy that the patient is getting from the dialysate. Otherwise, the rest of the prescription is the same. Normalized plasma branch-chain amino acids, because our patients are low in branch-chain amino acids. So you have to administer relative large amounts of branch-chain amino acids through interdietary parenteral nutrition that you can do while you're giving hemodialysis, or you can give 1.1% intraperitoneal amino acid infusion to the patients who can afford it. That will really improve their nutritional status. And the rest, other things are just the same. There's no other difference. In PD patients, dextrose-based solutions result in net positive calorie gain due to glucose absorption, and this results in decreased intake of protein and fat intake. So patients on PD can obtain about 19% of total energy intake from dialysate glucose absorption. So they can, they can actually gain about 300 to 500 kilocalories per day. And so the patient feels satiety. He has satiety, he feels satiated, and so he doesn't feel like eating much. So in such cases, you have to tell the patient to first take the protein, foods containing protein, and then go for foods with carbohydrates. The rule of the thumb is to reverse protein loss, give high protein diet to patients on dialysis, and at least 50% of this protein should be of high biological value. To increase protein and energy intake, prescribe renal-specific oral supplements in between the meals. For sicker patients, use energy-dense protein formulas. ONS can actually provide about 10 kilocalories per kg body weight per day to the patients. And here you can see that, don't expect miracles to happen. When you start supplementing your patient with oral nutrition supplement, you have to wait for some time. It will take about 3 months for the serum albumin to start rising up, and then it will keep on rising. But the moment you stop giving, the serum albumin will start coming down, especially in PD patients. So for PD patients, you need a protein supplement which is very, very high in protein. Now, we all have seen the COVID pandemic, and we're still seeing it. So in such unforeseen circumstances, the patient can abstain from dialysis because he cannot reach the dialysis center. So what do you do in such cases? Are you still going to give him 1.2 or 1 gram per kg body weight per day of protein? I'm talking about the hemodialysis patient, not the petroleum dialysis patient. They are fine, happy doing everything at home, so they can eat very well. So if the patient is missing dialysis, what you should do is, on a non-hemodialysis day, advise protein-free diet and restrict foods rich in potassium and phosphorus. And on a dialysis day, increase protein intake to more than 1 to 1.2 grams per kg body weight per day to compensate for hypercatabolism triggered by the hemodialysis. Now, Giovanni and Locati, they came up with an integrated dialysis dietary program, but it failed. But then later on, the message that I'm going to give you is they decided that 0.6 grams per kg body weight per day should be given to the patient on hemodialysis along with keto analogs. So when the patient is on keto analogs, the nutritional status will not worsen, the uremic symptoms will not appear. So this is an option which you can give to your patients. And they found that there was a high cumulative survival in this kind of a diet prescription at 96 months. And also, it also preserved residual renal function in the patients because they were able to avoid the need for ultrafiltration for a longer period of time, given that more frequent dialysis could worsen renal perfusion. And also this paper, again, is from Stefania Karia, which says if the patient is on infrequent dialysis, once a week session combined with very low protein diet, low phosphorus diet, and supplemented with keto analogs will keep your patient really healthy and free from uremic symptoms. Now, we have to prevent hyperkalemia in these patients because high serum potassium requires potassium restriction. And you know that 1 gram of protein brings 1 milliequal of potassium. So serum potassium actually correlates closely with nutritional markers, in particular the NPCR, suggesting that patients who eat more protein also tend to have a high serum potassium level, obviously. And hyperkalemia can result from acute exposure to high potassium meal or from accumulation of potassium from consuming high potassium diet. So that's why you do not allow your patients to take mangoes regularly. Once in a while, they can take 1 or 2 slices of mangoes, but no melons and watermelons. These are all very high in potassium, so you can't give your patients these things. Now, this figure is showing you that the best pre-hemodialysis serum potassium range associated with greatest survival is when the potassium level is between 4.6 to 5.3 milliequals. Potassium levels of less than 4 and more than 5.6 are associated with increased mortality. And here again, pre-dialysis serum of 4.6 to 5.3 milliequal is associated with greater survival in hemodialysis patients. Okay, and the hyperkalemia. All right, fine, yes. Hyperkalemic patients who undergo maintenance hemodialysis against lower dialysate bath may have a better survival to prevent deleterious cardiovascular effects and therefore correct serum potassium levels. Now moving on to hyperphosphatemia. In CKD stages, the serum albumin, serum phosphate levels should, anything above 4.6 is considered hyperphosphatemic. And in dialysis patients, anything above 5.5 is considered as hyperphosphatemic. So which kind of protein would you prefer for your patient? Animal protein or a plant protein? Now, prefer plant-based diet because only 40 to 60% of phosphate is absorbed. But if you give up animal protein, then 80% of phosphates will be absorbed. So, and you know that you have to restrict phosphates to between 800 to 1000 milligrams per day. And you know that protein has a linear relationship with phosphates. So as you increase protein intake, the phosphate intake also, phosphorus levels also go up. And you remember that 1 gram of protein contains 13 to 15 milligrams of phosphates, of which 30 to 70% is absorbed to the intestinal lumen. So high phosphorus levels put your patients at the risk of developing and the progression of cardiovascular disease and mineral bone disease. So one can use phosphorus pyramid to choose foods low in phosphorus. This is a very nice pyramid. You just go through it. It is available on the internet. And of course, for a pre-dialysis patient, advise low protein diet. For a patient who is on dialysis, advise them, things like egg white, because they are low in phosphorus to potassium to protein ratio. And also advise foods containing 12 to less than 40 milligrams of phosphorus to protein ratio, because the risk of mortality increases if the phosphorus to protein ratio goes up beyond 16 milligrams per gram. Prefer plant protein. Highest load of phosphorus comes from protein-rich foods like nuts, hard cheeses, egg yolk, meat, poultry, and fish. And here you can see this is a study which is showing you meat diet versus plant diet. So you can see the plasma phosphorus levels, the intact PTH level, and the diurnal variation in the fractional excretion of phosphorus is lower in plant-based diet compared to the meat-based diet. Avoid dals which are, with chilka, because otherwise the patient will get a lot of phosphorus, and remove choker from wheat flour. And the source of plant foods as dietary phosphorus are legumes, nuts, chocolates, along with inorganic phosphorus in the form of food additives. Egg white is an unusually rich source of high biological value protein and one of the lowest phosphorus protein ratios, and is also devoid of cholesterol, so you can prescribe it. Avoid foods which are which have phosphorus-based additives like cola beverages, enhanced or restructured meat, frozen meals, cereals, snack bars, processed or spreadable cheeses, instant products, refrigerated bakery products. And of course, phosphate binders are a must for our patients. However, if the patient has, the study has shown that if the patient has residual renal function, then they require less number of phosphate binders compared to patients who are anuric. So try and preserve the residual renal function of your patients. Now, one regular hemodialysis can clear up to 800 milligrams of phosphates, but dialysis sessions are given just twice or thrice a day. So therefore you have to restrict phosphate intake, and you have to prescribe phosphate binders, and 1 day of Petroleum dialysis approximately clears 300 milligrams of phosphates. So phosphate binders are a must for the patients. Boiling will reduce phosphate content with negligible loss of nitrogen, leading to a more favorable phosphorus to protein ratio. So you can advise the patients to boil legumes if they want to have legumes. Now, gut is a forgotten organ in kidney disease and uremia. And of course, the patients do have dysbiosis and inflammation. So this figure is showing you the high total serum concentration of indoxyl sulfate in dialysis and precursor in dialysis patients. And this is how the dialysis clears indoxyl sulfate precursor, but they are not cleared completely. So if the patient is missing dialysis or is not doing very well, then you should have to add fiber to the diet, at least 25 to 35 grams of fiber per 22,000 calories. So the take-home message of my talk here is, counsel your patient, monitor dietary intake, individualize dietary prescription to prevent setting in of protein energy wasting. In pre-dialysis patients, that is in CKD stage 2 to 5, non-dialysis low protein diet is something that you have to prescribe. I've taught you 3 different types of diets. You choose which you want to give to your patient. Because low protein diet can retard progression of renal failure and delay time to dialysis, plant-based diets can alleviate hyperphosphatemia and metabolic acidosis, improve blood pressure control, insulin sensitivity, lipid profile, reduce proteinuria. Very low protein diet with ketone rocks and preserve nutritional status, monitor potassium to prevent hyperkalemia. Excessive protein restriction without monitoring of nutritional status can lead to malnutrition. High protein and high energy diet for patients on maintenance dialysis is a must, and you must prevent and try to control formation of uremic toxins. All right, so that's it. This is a pyramid that I drew for prevention of muscle catabolism. So yes, of course, you have, the patient is anorexic, you have to prescribe appetite stimulants, and resistance exercise is important for both the CKD patients, the pre-dialysis, as well as the dialysis patients. And thank you for your attention. Hello, boys and girls, are you still around?
Yes, ma'am.
Yeah. So I'll straight away move on to the next talk. I hope things were clear. Do you have any questions?
Yeah. Good afternoon, Dr. Anita.
Yeah, hi, Dr. Dhabi, you've joined.
Yeah. So I have one question for you. Then, since you
No,
talk lots
Dr. Dhabi,
of,
you cannot ask me a question right now. You have to first give your lecture and then my. Do you want to give a lecture now?
Yeah, please.
Okay.
I appreciate that.
Yeah. So let me introduce Dr. Dhabi. I think you must all know how good he is. I take this opportunity to introduce our first faculty this afternoon, who is an international figure and a pioneer in the field of medical nutrition, Dr. Ashwin Dhabi, who is a consultant physician from Ahmedabad. He has been president of Indian Association for Parental and Enteral Nutrition. He's a course director of European Society of Parental and Enteral Nutrition for lifelong learning workshops in India. He's member contributor for ESPN 2021 guidelines for kidney failure and hospital food, and he's a member executive council ESPN and IPN. I have especially invited him to introduce you to therapeutic nutrition and how to prevent hospital-acquired malnutrition, hence this introduction. So over to Dr. Dhabi.
Thank you so much, Dr. Anita, for a kind introduction. Good afternoon, friends. And I'm very happy that my job has been relieved, because Dr. Anita has very excellently elaborated that if you don't address the nutritional adequacy right at the frontline treatment management, I think we'll end up in a trouble. So the objective of this talk is to briefly introduce about the important role of medical nutritional therapy in management of patients admitted with acute diseases, and better how to assess this patient. So this is we have been doing for a pretty long time. That malnutrition, we understood that it is only cachexia or the kwashiorkor and marasmus. But now it's a broad terminology that malnutrition includes everything, that is undernutrition, overnutrition, micronutrient deficiency, and fluid and electrolyte balance. This was a wonderful publication from ISRNM, and you see that we are harboring the sickest people with CKD across the globe. And similar study, if you look at the prevalence of protein energy wasting, which is a form of undernutrition, the prevalence rates are more than 60% in our country. So this is we have been doing for a long time, that once the patients are in a hospital bed, if we don't address the nutritional support, this will become a skeleton over a period of time. Unfortunately, the scenario is very pathetic in Indian setup. Many a times, apart from nephrology, we do not even bother to check the height and weight of the patients. Whatever the illness, whether you take it respiratory, kidney failure, gastro, oncology, sepsis, burns, trauma, everything leads to undernutrition. So this was a very wonderful metabolic pathways elaborated by Dr. David Cuthbertson in 1930 in a patients with fractured hip. And what they found that for initially 24 to 48 hours, this patient were in a state of shock, or we call it a hypometabolism. And then over a period of few days to few weeks, and now we see people with a chronic critical illness for few months, they remain hypercatabolic. So this is a phase, whether you do nutritional support or not, the body is going to use the endogenous proteins to provide the energy and the acute phase proteins. So the metabolic response to critical illness is very tricky. All substrates are undergoing a rampant phase of catabolism, whether it is a proteins, whether it is a carbohydrate or it is a fatty acid. So our body gets depleted of not only the energy stores, but also the depletion of the amino acids. And that is all because of the very complex neuroendocrine response. There is a cytokine storm and there is the activation of sympathetic nervous system. So friends, this is, we have to address each cascade of the inflammatory syndrome, because malnutrition, if you don't address, the consequences are far reaching. Meaning thereby, this was a wonderful publication from my friend Dr. Tommy Sederholm. And on admission till the discharge, they categorize patients into protein energy malnourished and non-protein energy malnourished on day of discharge, and they observe them for next 9 months. And what they found, very surprisingly, that those patients who lost weight during hospitalization, the mortality was almost 4 times higher up to the 1 year after the discharge. So this is very important. We want to address malnutrition right from the day one of the patient care. There are lots of barriers in countries like India where do not patients in hospital, they spend increased days on ventilator or renal replacement therapy or in ICU. And in patients in community, if they are malnourished, they frequently go to the OPD clinics, they frequently require hospital admission, and that everything leads to the increase in the healthcare burden. So this is very important to identify the nutritional inadequacy. But everything we started learning very fast when the COVID came. So we were fortunate to present then this paper on the nutritional support in COVID, because we never had any strong antiviral drug. And therefore, we realized that addressing a nutritional inadequacy in any sickness is very patient, whether they are having a low body mass index or there is a loss of appetite or there is a food intake is not at par with the energy requirement. All these people, they are at a high risk of nutritional deficit. So your identification of nutritional inadequacy should lead to the action in form of nutritional support. So first step in the nutritional intervention is to identify the vulnerable people. So this study, which came from a Dutch people, and they group these elderly people who were staying in a hospital and nursing home. They did a mandatory nutritional screening, and they also had a nutritional support for those people, and they compared them with those community dwellers who never underwent nutritional screening and nutritional support. And over a period of next few years, those people who left were not given any nutritional attention, they become undernourished. So this is very important that we have to address the nutritional inadequacy. So as I already mentioned that how to identify these people is by doing a brief ABCD examination. So that is nothing but anthropometry, biochemistry, clinical examination, and the dietary survey. So this is very important tool to identify vulnerable people wherein which we can give the nutritional support. I was a part of the GLIM working group, and this is very, we do screening by using any validated screening tool like NRS, or you can use MST, MUST, whichever, Nutrix score. And then you do the assess the nutritional inadequacy by checking for the phenotypic and the etiologic criteria. And presence of one of them means the patient is at risk of undernutrition. So this is very important. We want to address the functioning muscle mass, because it is a muscle mass and muscle function which is ultimately going to give us a good body functioning. So there are various means we can do and look for the lean body mass, like be a body composition analysis, DEXA, CT scan, and nowadays ultrasonography. We did one study by using a calf circumference, and this data we were able to present in the European Congress. And what we found out that when you do the nutritional assessment, not only you are able to identify the people at risk of nutritional depletion, but also what you can look for a lean body mass. And what we found in our patient that most of our patient has a calf circumference of less than 32 centimeters. So these people were severe or moderately malnourished, and this you already know adversely affect the outcome. So this was a Aspen Sandersment on the various cutoff values, and if you look at the uh, Asian cutoffs, which are smarter than the European cutoff, and we always take these figures, whether it is a gender-based classification, to address the nutritional inadequacy. So like what is already being said by Dr. Anita is giving enough calories, enough protein. But I would differently address the undernutrition by addressing these three key components. One is to address the muscle mass. Second is to address the muscle function. As third is to look at the inflammatory activity. So this was one of my very close friend, Dr. Paul Wiesmeyer. He was recently undergoing abdominal surgery. So as a part of pre-rehabilitation, we do the body composition analysis and just to find out what is all going on. And there are various parameters we can identify in the body composition analysis. One is a lean body mass. Second most important is a phase angle. Phase angle is an angle if it is more than 6, you probably are in a green zone. And if it is less than 5, I think that is a risk for perioperative worst outcome. Apart from that, we can also look at the other parameters of the body. So if you look at the data from this study in all three patients, CKD versus end-stage renal patients on dialysis and transplant patient, if you look at the phase angle, it has worsened from CKD to the end-stage renal disease. And a moment they undergo renal transplantation, there was a marginal improvement in the phase angle. Similarly, if you look at the muscle indices, there were similar improvement once you correct the cause of catabolic stress. So there is a strong association between the visceral adipose tissue versus chronic kidney disease. All of we learned that visceral adipose tissue is one of the largest endocrine organ in the body, which releases lots of cytokines. The other and easy method of looking at the muscle mass is to do a bedside ultrasonography. Now comes only with a handheld device. So this is, you can actually measure the cross-sectional area. Apart from that, we can do the 6-minute walking and the accelerometry. So these are all important to know whether we can have to address the nutritional in a prehabilitation phase, meaning thereby 1 to 2 weeks before the surgery, and we might continue post-operatively. So given all the condition, if you look at the methodologies which are available, I think the calf circumference, DEXA, and the body bioimpedance analysis are practically more useful compared to rest of the other parameters like MRI and the ultrasonography. And we have a very well-defined cutoff values, including the ethnicity wise, like the Caucasian or the Asian population, at least for the first three parameters like arm muscle circumference, and BIA. Coming to the third and the last part is to know about the inflammatory status, because inflammatory status itself leads to the stimulation of a catabolic hormone and inhibition of the anabolic hormones like insulin and growth hormone. Every condition, whether acute and chronic, they have subclinical to very high grade of inflammation. And many of our patients in hospital are with 3, 4, 5 diagnoses. So this was a wonderful study. We call it a effort trial, in which we categorize patients in according to the level of C-reactive protein into mild, moderate, and severe inflammatory stress. So first tertile is a mild inflammation with CRP values less than 7, moderate with 10 to 100, and severe stress with more than 100. And the baseline characteristics were quite similar. And if you look at the body mass index, more number of patients in an inflammatory arm had undernutrition. So this is very important. We just want to address the nutritional support in all three type of patients. But the wonderful thing is that if you compare all three group on a one graph, there was a better survival when we delivered a nutritional support to all 4 group of patient compared to the control arm where patients received only standard of care. But the response to the nutritional support was more pronounced when the inflammatory stress was mild to moderate. So there was a statistically significant difference not only at the 30-day but also at the 6 months mortality data now available with us. And when there was a high inflammation, the outcome was not that better. So meaning thereby we have to address the nutritional intervention right at the initiation of illness. Most of our patients, they do not complete their meals when they are offered bedside. And also there is a inadequate training and the lack of equipment in our hospital beds. So majority of our patients are suffering from malnutrition because of there is a lack of national policy, lack of institutional policy, and there is a lack of skilled healthcare force. Everything leads to the insufficient energy and protein intake, which worsens the disease-related malnutrition. So there are lots of barriers in our country, but I just want to elaborate. There are innumerable nutrition societies are existing in our country, and there is a lack of coordination among each other, and there is lack of networking. So we do not have a uniform nutritional practices across the various part of India. And also, all of you know that lots of other interventions like CT scan or pleural tapping or gastric aspiration, physiotherapy, they are all leads to interruptions in delivering the nutritional needs. So this is very important. We just want to know that why we want to address. So this was a wonderful study which has come from the Latin America, and what they identified in all those patients who were tube fed, that at that time the caloric target was 20 kilocalorie per kilogram per day. So only half of the patient they met the caloric needs. If we apply 25 to 30, this figure will jump to 75 to 80%. And almost only 20% of the people, they were able to push the protein 1 gram per kilogram body weight during the 1 week of hospitalization. If you put the protein today, we like to give is 1.2 to 1.5 gram, then this value will come only 5 to 10% of patients. And this was a wonderful study from Ellingstrup and group. And what they find that if you meet only the protein needs during the first week of ICU stay, you if irrespective of your all other caloric needs, then also you are able to improve the survival in those patients where the high proteins were delivered during the early course of intervention. So this is very important. We want to address the caloric and the protein needs in the patients who are landed with a acute illness in the hospital. These are well covered by Dr. Anita. I don't want to go into the detail. And the other way around, that whenever it comes to hospital, there is always a fight between physician and surgeon. Surgeons, they like to give the parenteral nutrition, and we physicians are bit conservative. We like to give the enteral nutrition. But truly speaking, this fight is not correct, because our aim is to give the calorie and protein. So this study, which has come from Dr. Gordon Doig and group from Australia, where they gave a early parenteral nutrition in those patients, there was a relative contraindication for early enteral nutrition. And what they found that in early parenteral nutrition group, they were able to achieve the caloric goal by day 4. And they were able to achieve the protein needs very early. So this is very important, whether you give enteral nutrition, you give parenteral nutrition, or you give combine both. Sooner and safer, most important. You should not overload the patient with calories and fluid. So safer is also very important. So sooner and safer you achieve the caloric and protein targets, I think that is the best way to address the nutritional inadequacy. All these things like bicarbonate levels and everything is discussed by Dr. Anita. Apart from the energy, protein, the muscle mass, muscle function, our patients are very complex with respect to metabolism. So typically, say for example, if we take a patient of hepatorenal syndrome, there is a problem in all pathways of anabolism, right from the gut absorption, right from the nutrient delivery till the assimilation in gut, and then subsequent peripheral utilization. So they have a strong anabolic resistance. So we have to give them a hormone replacement or aromatase inhibitor. There is a mitochondrial dysfunction. So we have to push them with a mitoprotective agents. already elaborated by Dr. Anita is a gut dysbiosis. So we have to smartly choose our antibiotics, or maybe you can use some elements which reduces the gut permeability. We can reduce the ammonia lowering agents which are responsible for decreasing the metabolic acidosis. There is a proteostasis, meaning thereby in spite of giving calories and protein, your muscle doesn't convert them into the muscle protein synthesis. So that proteostasis is being stimulated by myostatin. So you have to give the myostatin antagonist. So similarly, all these features of branch amino acids, accelerated catabolism, inflammatory stress, and a structured exercise program. If you give optimum energy protein and a very special substrate like omega-3 fatty acid or glutamate, but if your patient doesn't move their hands and legs, doesn't shake your body, doesn't do breathing exercise, all your nutrition support is going to be wasted. So this is very important that physical activities must, even in every patient, even during the dialysis, during the ventilation, they should be doing some sort of exercise. So the nutritional care for preventing malnutrition in a hospitalized patient is a protocol-based intervention. I would earnestly request all of you to do a brief nutritional assessment, estimate the energy and protein requirement, and then try to optimize how best you can deliver these nutrients by optimizing and reducing the unnecessary interventions by repeated gastric residual measurements. Do not throw away the gastric aspirate. You should ideally refeed the gastric aspirate because it contains lots of amino acid, enzymes, minerals, and electrolyte. And there should be a multidisciplinary team which includes a trained physician with a excellent knowledge in clinical nutrition, a very smart dietitian, a physiotherapist, nutrition specific pharmacist, and nutritional dedicated nurses. So this is, I just want to end that nutrition is nothing but to give a optimized and a very smart delivery of day-to-day foods, but in a very scientifically proven way. Thank you so much.
Thank you, Dr. Dhabi, for that elusive talk. In fact, I really enjoyed it. And I'm sure, I mean, you should have gone first before I did my lecture, because that was what, you should have set the ball rolling. It's a wonderful talk. We do not have time for question and answers because I have to cover another case. So I'll move on with my case now. I'll try and finish it within 25 minutes. It's already, I think, what is the time now? It is, all right. So I should be able to finish my this is no, this is not the one. This is not the one. This is the one. No, this is not. Okay. This shoe. This is the one. This is the one. Diagnosis. Yes, this is the one. Okay. So I'll share my screen. This is the one. And share. Yes. Okay. Right, boys and girls, I'm going to take up a case. This will a lot of things I hadn't covered up in my talk in the first lecture, but this will cover up many things. So this is diagnosis and management of right. This is diagnosis and management of malnutrition in CKD patients and patients on dialysis. So the outline of my talk is I'm going to discuss this diabetic patient with CKD and poor nutritional status. So this is a 74-year-old woman with diabetes for 15 years, hypertension, hypercholesterolemia, and osteoarthritis, and CKD for more than 10 years. CKD was attributed to diabetes, that is, she had diabetic kidney disease. She presented with nausea and vomiting for several weeks, attributed to a gastrointestinal viral disease. There was slow deterioration of renal function over the past few years. She had poor appetite, some taste changes, sleepiness, and decreased physical activity for the past few months. She had lost 7 kilograms of weight in the last 6 months. She was less able to care for herself and was having difficulty maintaining her regular activities. She had actually lost her husband, and her children were living away from her, so there was nobody to help her with her daily errands. So medications, she was on metoprolol, then lisinopril, furosemide, atorvastatin, sodium bicarbonate tablets, calcitrol, and riboride. Now, the physical examination on admission showed body weight of 68.5 kilograms, body mass index of 28.5, blood pressure of 115 by 65 millimeters of mercury, heart rate was 65 beats per minute. She was in no apparent distress. There was mild to moderate muscle and fat wasting. Her skin and mucous membranes were dry. Lungs were clear and her cardiac examination was unremarkable. Her abdomen was soft and non-distended, and she had 1+ edema of the feet and ankles, and neurological examination was unremarkable. So this is the laboratory report of this female. The creatinine before she came to the hospital, 6 months prior to that, was 2.5, which had progressed to 3.6. Then her albumin levels were 3.4 6 months prior, and they had declined to 3.2 when she came for admission. And the phosphorus levels were within normal limits for 6 months ago. But when she came here, she was hyperphosphatemic. HbA1c was 9.2. This means she had uncontrolled sugars, and it was 9.4 on admission. And then the GFR was 12. Okay, so we move on. Now, during this hospitalization, she was treated with intravenous fluids and her kidney function improved. Diabetic gastroparesis was diagnosed and she was started on metoclopramide. She was evaluated by a dietitian. The dietary assessment revealed daily intake of 1200 kilocalories of energy, 40 grams of protein, 80 mmol of potassium, and 800 milligrams of phosphorus. She was discharged in a stable condition. When she was discharged, her creatinine was 3.1, albumin was 3.3, and hemoglobin was 10.8. And phosphorus had come down to 4.2, within the normal range for a CKD patient. Now, 4 months after discharge, the patient was brought to the emergency department with failure to thrive and shortness of breath on exertion. Her laboratory findings showed a creatinine of 4.7, albumin had dropped down to 3.1, hemoglobin had dropped down to 9.8, GFR was 9 ml per minute, and therefore she was initiated on maintenance hemodialysis from pre-dialysis. Now she is into ESRD. She was discharged home after 3 hemodialysis sessions and was referred to a dialytic clinic for continuation of her outpatient maintenance hemodialysis. So this is the third encounter. Creatinine is 4.5, and all right, then later on we come back. Now, 5 months later, after the initiation of dialysis, she was admitted to the hospital with low-grade fever and chills. She stated that she did not tolerate meals well, usually less than half consumed, and had very poor appetite. So initially she was taking 1200 calories. Now she was taking 600 calories of energy. She was initially taking 40 grams of protein, and now she was taking about 20 grams of protein. So she was malnourished as it is. The dietary intake points towards that. Now serum albumin had dropped to 2.9. So another indicator of malnutrition, and this is actually showing the declining nutritional status. Her urine output had also dropped to less than 200 ml per day. She fell sick towards the end of her hemodialysis treatment, and usually after the 3rd hour, and often signed off early because of the cramps. So therefore, her dialysis dose was inadequate. And so she was continuing to having uremic symptoms. Her physical examination on admission revealed the body weight of 59 kilograms, which means that she had lost about 9 kilograms of weight, and body mass index of 24, which had come down from 28 to 24. Blood pressure was 110 by 60 millimeters of mercury. Serum albumin was 2.9. Her skin and mucous membranes were dry. She had trace edema of the feet and the ankles. So this case, let me summarize the case now. This case illustrates a common scenario in which a patient with CKD progressed to ESRD, was initiated on maintenance hemodialysis and endured several complications during this transition and the initial 6 months of ESRD, including a subtle but clinically important progressive deterioration of her nutritional status. CKD leads to a state of metabolic and nutritional derangements, protein energy wasting, and is evident from the loss of body weight, BMI, appetite, and uremic muscle wasting. So this is what we see in our OPD and also in the wards. The stabilized serum creatinine of 4.9 milligram percent was not the true creatinine for this woman due to the loss of muscle mass. Hence, despite being on intensive hemodialysis, she was unable to eat well, and that means that she was uremic. Protein energy wasting is closely associated with major adverse clinical outcomes, such as increased rates of hospitalization and death. In patients with ESRD, therefore, nutritional intervention plays a vital role in clinical outcome. Right. So you've already seen this figure in my previous lecture that the prevalence of protein energy wasting is about 18 to 48% in CKD stages 2 to 4, and it goes up to 75 in ESRD. And as the CKD stages increase, the appetite worsens. And also, I told you that the protein energy wasting most likely sets in during the CKD stage 3 or even earlier, because of inadequate nutritional management, the pre-dialysis phase, and becomes clinically evident when GFR declines below 10. And this also you've seen that the GFR has a direct relationship with the serum albumin level, then dietary protein and energy intake, indicating a decline in circulating protein levels or serum protein concentration due to protein losses or inflammation. So we are talking about CKD stage 3, GFR less than 60 ml per minute. So dietary modification is recommended in the management of chronic kidney disease. Individuals with CKD often have significant comorbid conditions such as high blood pressure, diabetes, cardiovascular disease, and obesity, for which dietary modification is also recommended. Dietary considerations in CKD can be numerous and complicated for both the provider and the patients. Adherence to a recommendation is difficult for patients to achieve. Now, guiding principles for nutritional management therefore include assessment and monitoring of nutritional status throughout all stages of CKD, creation of an individualized yet comprehensive nutritional plan that meets clinical guidelines and will have favorable effects on CKD and associated comorbidities, and recommendation of meal plan that is feasible, sustainable, and suited for the patient's food preferences and needs. So let's see how do we approach a CKD patient on conservative management and on maintenance hemodialysis. So we start with nutritional screening. Dr. Dhabi has already told you everything about this, but anyways, I'll be touching upon it. Then after nutritional screening, we go for nutritional assessment. So what is nutritional screening? Nutritional screening is a process of identifying patients at risk of malnutrition so that more extensive nutritional assessment can be performed. It is simple and rapid. The screening tools address 3 or 4 basic questions like recent weight loss, current body mass index, disease severity, and recent food intake. While nutritional assessment is a more detailed diagnostic process which characterizes the degree of malnutrition, risk of medical complications related to malnutrition, and the need for nutrition support, and it is used for monitoring the course of nutritional therapy. So this nutritional assessment requires biochemical profile, it requires certain other investigations, maybe ultrasound or DEXA or many more things, but this can take from few days to few weeks for you to complete the nutritional assessment. Now, a clinically meaningful assessment of nutritional status should be able to identify and risk stratify patients with protein energy wasting, distinguishing causes and consequences of both protein energy wasting and underlying disease states, and to determine whether there is potential benefit from nutritional intervention or not. There is no single nutritional marker that can adequately phenotype this comorbid state, and a comprehensive assessment of protein and energy nutritional status requires several different measurements. So for diagnosis of malnutrition, you require several tools which are already validated. Dr. Dhabi has already spoken about MUST tool. So this is Malnutrition Universal Screening Tool, MUST, which is the simplest tool to use. It has 5 steps. The step 1, step 2, and step 3, they talk about the BMI, and the scoring is done based on 0, 1, and 2. Then you have weight loss score, and then you have acute disease effect score. When you add this up, you come up with an overall risk of malnutrition, and later on you come to know whether the patient is at risk of developing malnutrition or not, or whether he is already malnourished. If the patient is not malnourished, then you reassess the patient as they move through care settings. The second score that the nutritional screening tool that we use is nutritional risk screening, that is the NRS 2002, which has again 4 questions on BMI. And these questions are answered as yes or no. So BMI less than 20.5, weight loss within 3 months, yes or no, reduced dietary intake in the last week, ICU admission, yes or no. And accordingly, the advice is given. And if yes to any proceed of the questions, then we proceed to final screening, and then we decide what to do, and the nutritional assessment is then done in detail. Now, NutriScore is a nutrition screening tool for ICU patients to identify adverse events and so that you can actually modify nutritional therapy. And it is recommended that all ICU admissions should be screened to assess need for nutritional support. And nutritional support should be initiated within 24 to 48 hours of ICU admission or once the patient is hemodynamically stable. Now, moving on to nutritional assessment, it has 4 steps. The nutritional assessment with several validated tools, nutritional diagnosis to name the specific problem, nutrition intervention, and nutrition monitoring and evaluation. So let's talk about nutritional assessment. Now, deterioration of clinical nutritional status is characterized by progressive weight loss, wasting of fat and skeletal muscle tissues, and reduction of serum proteins. So Ckd Update 2020 recommends routine nutritional assessment using dietary recall, 24-hour or 3-day food recall, maintaining dietary diaries, food frequency questionnaires, and NPCR. Then they have recommended 7-point subjective global assessment, malnutrition inflammation score for dialysis patients, then assessment of body composition with technical devices like BIA, DEXA, hand grip strength, and anthropometric measurements. So these are all, Dr. Dhabi has already touched upon everything. I'm not going to talk to you about this at all. And so there is a lot of data on reliability of technical devices for assessment of body composition. Let's have a look at this. So the BIA and the DEXA, they have a very strong correlation when it comes to fat-free mass and the lean right leg mass. Compared with DEXA, multi-frequency BIA appears to be a robust tool for measuring and monitoring total body fat and lean body mass in hemodialysis patients. And also there's a strong correlation between the two in the lean trunk and the left lean arm. But when it comes to the bone mineral content, the two do not match very well. So one has to be very careful in which one to follow. Now, hand grip strength gives a valid measure of nutritional status compared to MIS in MHD patients. The sensitivity is 70 to 87%, and the specificity is 43 to 66%. And lower hand grip strength values are independently associated with higher malnutrition inflammation score among patients on maintenance hemodialysis. So HGA is a valid and clinically useful measure of protein energy status, and it correlates with objective measures like albumin, weight, dietary intake, and anthropometry. So this is a proforma. This is how an SGA score proforma looks like. It has 2 parts, the medical history, and part 2 is a physical examination. So the medical history takes into account the weight changes, the recent weight changes, whether weight gain or weight loss, and then dietary intake, whether the patient has been on hypocaloric diet, fluid, full liquid diet, or starvation, or whether the patient has gastrointestinal symptoms like nausea, vomiting, diarrhea, anorexia, whether the patient has any functional impairment or not. And the physical examination includes loss of subcutaneous fat, muscle wasting, edema, and ascites, and accordingly, the patient is weighted as well-nourished, mildly to moderately malnourished, or severely malnourished. A higher SG score is associated with a lower relative risk of death and fewer hospitalization days, according to the Kenya study. And this is how you identify malnutrition. You see whether the patient is edematous, he has skinny looks, or he looks exhausted. The physical examination, you would be doing the signs, you'll be looking for signs of muscle wasting. Now, International Society of Renal Nutrition and Metabolism has come up with the diagnostic criteria for protein energy wasting, which has 4 indicators: the serum chemistry, body mass, muscle mass, and dietary intake. Now, serum chemistry takes into consideration the serum albumin level less than 3.8 grams per deciliter, the serum prealbumin less than 30 milligrams per deciliter, or serum cholesterol less than 100 milligrams per deciliter. Body mass index includes whether the BMI is less than 22 if the patient's age is more than 65, or less than 23 if the patient's age is less than 65. Unintentional weight loss of 5% in 3 months and 10% in 6 months, and total body fat percent less than 10%. Now, muscle mass wasting is also very, very important criteria. So whether the patient has reduced muscle mass 5% in 3 months or 10% in 6 months, reduce mid-upper arm muscle circumference of more than 10% reduction in relation to the 50th percentile for the reference population, and dietary intake, that is, the patient has had unintentional weight loss, unintentional low dietary protein intake, or that is 0.8 grams per kg body weight per day for at least 2 months for maintenance hemodialysis patients, or the patient is on conservative management, then less than 0.6 grams per kg body weight per day between stages 2 to 5 with 5 grams per day of urinary protein loss, and unintentional low dietary energy intake of less than 25 kilocalories per kg body weight per day for at least 2 months. Now, in this patient, the patient was losing serum albumin, so serum albumin was declining, and the body mass index also declined. There was muscle wasting, and the dietary intake had gone down. So this patient was suffering from protein energy wasting. Out of 4 criteria, 3 should be positive, which we saw. In fact, all the 4 criteria were positive, and from each of the 3 criteria, at least 1 criteria should be present to diagnose protein energy wasting. So this patient was diagnosed as having protein energy wasting. Now, moving on to nutritional diagnosis, naming the specific problem. So you have to see the quantitative nutrient intake as undernutrition or overnutrition, whether the patient has had inadequate or excessive protein, energy, fat, fiber, minerals, or disordered eating habits, or he's going through some kind of a depression. That's also very important. Now, according to the Ckd guidelines, one has to maintain serum albumin at more than 4 grams per deciliter and prealbumin at more than 30 milligrams per deciliter. And the 50% of this protein should be of high biological value from milk, cottage cheese, eggs, fish, yogurt, lentil, and soya. Now, I have already told you that serum albumin is a marker for risk for hospitalization and mortality rather than a diagnostic marker for presence or absence of protein energy wasting. Now, coming back to the patient, this patient's serum creatinine was growing, and so she had become ESRD, and eventually she was started on maintenance hemodialysis. Albumin had declined from 3.4 to 2.9. HbA1c was 9.4, and later on it was not tested. Urinary spot albumin creatinine ratio was 3.5, 2.4, and later on it was not done. And then estimated GFR had declined to 9, and then she was actually started on hemodialysis. Now, we'll be talking about diabetic kidney disease because this patient was suffering from diabetic kidney disease. The challenges in DKD are controlling blood glucose, blood pressure, and dyslipidemia. So hypertension as mechanical stress and hypoglycemia trigger multiple common signaling pathways, especially increased angiotensin II that accelerate podocyte injury and cause impairment of the kidney and renal failure. Hypoglycemia causes the formation of AGs, which triggers oxidative stress. So here, if you have a look at this figure showing the increased extracellular glucose triggers apoptosis of podocyte through increased activity of caspase-3. Now, hyperglycemia-induced oxidative and nitrosative stress have been singled out as one of the major links between diabetes and diabetic complications. The persistent increase in reactive oxygen species and reactive nitrogen species, accompanied by a decrease in antioxidant activity, leads to the occurrence of oxidative and nitrosative stress, which causes endothelial dysfunction, insulin resistance, alterations in the number and functions of pancreatic cells, and eventually leads to diabetic microvascular and macrovascular complications. Now, once ROS and RNS are produced in excess, they cause structural deterioration of macromolecules such as the carbohydrate, protein, lipids, and DNA, leading to their instability and consequently loss of function. Now, this figure is showing you that high glucose increases ROS synthesis and induces podocyte apoptosis through activation of both plasma membrane and NADPH oxidase and mitochondrial oxidative stress. So NADPH oxidase is a key mediator of podocyte apoptosis and subsequent diabetic glomerulopathy, thus linking hyperglycemia, ROS, podocyte apoptosis, podocyte depletion, and diabetic nephropathy. So the goals of medical nutrition therapy in this case are to maintain near normal blood glucose levels by balancing food intake and exercise, that is physical activity, reducing albuminuria to less than 1 gram per deciliter, achieving optimal serum lipids, blood pressure to reduce the risk of CVD, adequate energy intake to attain or maintain reasonable body weight, and prevent malnutrition, maintain nutritional status, and improve quality of life through appropriate food choices and physical activity, achieve acceptable biochemical parameters and fluid status, and prevent and treat long-term complications. Now, diabetes complication control trial and its follow-up, epidemiology of diabetes and intervention complications, United Kingdom's prospective diabetes study, have all pointed out that patients with early stage of diabetes mellitus 1 or 2, intensive blood glucose control early in the course of disease, provided no further insults are imposed, exhibits a long-lasting favorable effect and can prevent irreversible damage on the risk of development of diabetic kidney disease. Now, the DCC trial has shown that 1% reduction in HbA1c correlates with 35% reduction in the risk of complications, 37% reduction in the microvascular complications, and 43% reduction in the amputation or death from peripheral vascular disease. So the target HbA1c of less than 7% should be there, irrespective of the presence or absence of CKD in diabetics. Low serum albumin levels are associated with severity of macrovascular complications such as nephropathy and retinopathy in diabetics. So correct hypoalbuminemia by improving protein and calorie intake and by correcting hydration status. Acute glucose fluctuations strongly correlate with triggering of oxidative stress and endothelial damage and cardiovascular disease. So hypoglycemia induces endothelial dysfunction through generation of oxidative stress. Therefore, combining antioxidant therapy, that is vitamin C, with the normalization of that glycemia can interrupt endothelial dysfunction. So one can supplement vitamin C, that's 60 milligrams to the females and 75 milligrams to the males. Now, elevated albuminuria is a strong independent predictor of anemia. Albuminuria causes excessive urinary loss of irons, transferrin, and erythropoietin, transcobalamin, and or other metals. So about half of the diabetic patients with anemia have inadequate iron stores. So therefore, one has to correct iron profile, supplement folic acid, iron B12, EPO if indicated. Now, use of vitamin D and its analogs may have potential for reducing albuminuria and slowing progression of diabetic nephropathy. The VITAL study, that is vitamin D receptor activated for albuminuria lowering trial, demonstrated a reduction in urine albumin excretion by 18%. Therefore, supplement vitamin D if deficient. This figure is showing you intensive control of blood glucose reduces urinary albumin excretion, and this ELIX study also has shown that intensive control of blood glucose reduces microalbuminuria. Now, dietary approaches to stop hypertension, Omni-Heart study, and Mediterranean diet and cardiovascular disease risk reduction, they all recommend reducing intake of saturated fats. Now, high saturated fat consumption is associated with presence of high albuminuria, as you can see in this data. And the lowering of dietary intake of saturated fat to less than 7% of total calories may be associated with improved outcomes through reducing this risk of high albuminuria. And there is a significant correlation between the HbA1c and carbohydrate intake. 60% carbohydrate in the form of diet high in cereals, fiber, lowers glycosylated hemoglobin in type 2 diabetes.
Dr. Anita, sorry to bother you, your slides are not moving.
Slides are not, where am I stuck?
Yeah, now I see.
Can you see the slide? Can you see the slide?
Yes, now we can
Yeah,
see.
yeah. Now we can see. But
So you missed all the slides? You missed
all the slides, I think.
Oh my God, that was interesting. Oh. So this is this. All right. You should have pointed it out earlier.
Anyway, go ahead.
Anyways, I think mainly 1 or 2 graphs, they were important. Otherwise, whatever I was saying was actually everything was written. Okay. So, well, amount of carbohydrate should be kept constant in these patients, and glycemic control to improves on 60% carbohydrate diet, which provides 150 grams of fiber per day. Increasing fiber would actually also control dysbiosis. Target fiber intake should be 25 grams per day from grains, vegetables, fruits, legumes, and nuts. So aim is to reduce fat consumption to reduce risk for cardiovascular disease. So advise leguminous seeds, lentils, soybean, as they produce only 20 to 40% of blood glucose rise that is seen after consumption of the same amount of carbohydrate taken as a wholemeal bread. Now, going back to the patient, the hemoglobin, the HbA1c was 9.4 in the beginning, and it came down to 8.6 later on. This was after nutritional intervention, and the serum albumin also, it had gone down to 2.9, and then it started to rise after intervention. So this lipidemia may increase albuminuria and accelerate progression of Ckd and RAS. Substitute grains and unsaturated fatty acids with fish, vegetables, legumes, and nuts. Control hyperlipidemia by reducing fat intake to less than 20 grams, limit saturated fats like red meat, whole milk, butter, and lard. Avoid foods containing trans fatty acids. Avoid hydrogenated vegetable oils. Increase carbohydrate intake, preferably unprocessed carbohydrate. This is OmniHeart study, which has shown that carbohydrate, once if you replace them by unsaturated fat, predominantly monounsaturated fat, it lowers blood pressure, triglycerides, and increases HDL cholesterol. So monounsaturated fat, I've already told you, it is olive oil or mustard oil. And one has to limit salt intake to less than 2.3 grams, and or maybe less than 1.5 grams if blood pressure is uncontrolled. And one has to restrict salty processed food and limit sugary foods, desserts, and many baked goods, and increase fiber intake. Now, baseline systolic blood pressure of 140 millimeters of mercury in patients with diabetes mellitus 2 has been associated with high risk of end-stage renal disease and mortality. Though antihypertensive drugs slow progression of renal disease, agents which
Again, Dr. Anita's slides are not moving.
Oh, okay.
Yeah, it's moving now.
All right. Agents which lower systemic blood pressure without correcting glomerular hypertension do not usually ameliorate glomerular injury, and we are concerned with avoiding glomerular injury in our patients. So for diabetics with CKD, the target blood pressure earlier on was 125 by 75 millimeters of mercury, and now it's probably 120 by 80. So the randomized controlled trial on soybean protein has shown that soybean supplementation results in reduction in systolic and diastolic blood pressure. Now, moving on to potassium. This lady was having hyperkalemia throughout, so probably because of RTA type 4. But remember that I've already shown you this slide that hyperkalemia is a known complication of RAS blockade and occurs in about 10% of outpatient and 38% of hospitalized patients. So whenever you initiate ACE inhibitors and ARBs, you have to monitor creatinine and potassium, and if the patient has hyperkalemia, you have to restrict potassium and stop giving them fruits and green vegetables which are high in potassium, and may have to resort to GI cation exchanges. And high potassium containing foods are grains, potatoes, sweet potatoes, corn, soya, bean, green vegetables, nuts, tomatoes, kiwi, melons, etc. Now, low protein diet should be given in pre-dialysis CKD. And I've already spoken about this, that you have three choices, whether you give conventional low protein diet or very low protein diet with keto analogs or practically vegetarian diets. And so in this case, the patient she was initiated on protein intake of 0.8 grams per kg body weight per day. As the GFR declined, protein intake was brought down to 0.6. Maintenance and when she was put on maintenance hemodialysis, the protein intake was increased to 1 gram, but she was not eating at all. Patient's intake of protein was 20 grams. So therefore, she required renal-specific oral nutritional supplements. Now, studies have emerged which have shown that plant protein has a therapeutic advantage. We've learned it in my lecture. Plant protein should be preferred over animal protein because there is less of fibrosis. And of course, we have to prevent hyperphosphatemia in these patients. So you have to restrict phosphorus to between 800 to 1,000 milligrams per day, and calcium between 1,000 to 1,500 milligrams if the patient is on vitamin D supplement. Of course, I've already spoken about preventing hyperphosphatemia. I don't think I have to go through again. But yes, one has to prevent or treat gastroparesis. This patient was started on metoclopramide. So one has to maintain adequate hydration and nutrition in this patient. Advise medium chain triglycerides if they do not delay gastric emptying to the same extent as common fat does. Advise small meals at frequent intervals consisting of low fat and complex carbohydrates. Meals containing fats and high fiber content should be avoided if the patient is symptomatic. Now, monitoring salt and water intake is an important part of the dietary therapy among individuals with advanced stages of CKD because as kidney function declines, salt and water retention is common. And fluid retention, you know, can exacerbate hypertension, lead to peripheral edema and asarca and pulmonary edema. So one has to monitor this. Now, a word about systemic inflammation. Inflammation is a major driving force for many uremic complications, including protein energy wasting. Systemic levels of pro-inflammatory markers are elevated in CKD and ESRD and are thought to play an integral role in the muscle catabolism of patients with ESRD. Now, elevated levels of IL-6 are associated with increased muscle petrolysis, an effect that can be blocked with administration of IL-6 receptor antibodies. IL-1 and TNF-alpha cause anorexia through effects on the satiety centers in the central nervous system. The initial step in treatment of inflammation should be elimination of etiological factors such as central venous HT catheters, which is directly applicable to this present case. Because of the dialysis procedure per se, the dialysis procedure might stimulate the immune system. Pro-inflammatory effects of the dialysis membranes and fluids should also be taken into account. Many uremic toxins are known to be pro-inflammatory and are inadequately removed with standard dialysis methods. So therefore, alternative methods or removal techniques such as strategies to modify intestinal generation or absorption by adding fiber or to the diet should be sought for, and appropriate management of fluid status might improve systemic inflammation in patients with ESRD because volume overload leads to immunoactivation and increased cytokine production via bacterial or endotoxin translocation. And this I've already said, you can introduce physical activity that will definitely bring down IL-6 and IL-10 levels. Then one has to combat metabolic acidosis. We've already discussed this in detail. And the treatment of protein energy wasting is basically oral and enteral nutritional supplementation. So, but this patient also had depression. So a word about this. Depression is common in our patients with end-stage renal disease on maintenance hemodialysis with prevalence rates ranging between 30 to 60%. And because of depression, they don't eat very well. And they're not even compliant to many instructions like water intake, etc. So there's a strong association between depression, inflammation, and serum albumin in maintenance dialysis patients. You can see the serum IL-6 levels, albumin, and comorbidities are closely correlated with symptoms of depression in patients on maintenance hemodialysis. And patients who are pre-dialysis, in them, patients with any degree of renal failure presenting with a sudden deterioration from the baseline function should check for the possibility of volume depletion to prevent decline in GFR. Well, fluid balance, I've already spoken. This lady went on to hemodialysis. So you have to adjust fluid intake and then salt intake. Patient here was not able to tolerate 4 hours of dialysis. Therefore, the patient was having inadequate dialysis dose due to hypertension. And such patient, therefore, should be put on intradialytic parenteral nutrition because her oral intake was bad. So she must have been on 1 gram per kg body weight per day of protein. The gut was functioning. If the gut is not functioning, prefer IDPN. But even if the gut is functioning, you can prefer IDPN on every dialysis. IDPN provides an average of 400 to 500 kilocalories and 30 to 40 grams of protein per dose. And IDPN should be infused at constant rate during a typical 4-hour dialysis session. 75 mmol of sodium should be added per liter of IDPN solution in order to compensate for sodium losses due to ultrafiltration. Now, provide intravenous liquid emulsion once a week at least. If you can, then twice a week. Replace electrolytes. Extra UF should be done equivalent to the IDPN volume infused so that the patient doesn't remain in volume overload. But the advantage of IDPN is that it prevents muscle catabolism. However, there is disadvantages that it is costly. So IDPN delivery should be progressively increased from 8 ml per kilogram during the first week to a maximum of 16 ml per kg IDPN without exceeding 1000 ml per hemodialysis session. 1000 ml is a lot, actually. It shouldn't be beyond 750 ml in any case. This is the composition of 1 liter solution of interdialytic parenteral nutrition. This is a commercial 3-in-1 admixture, which has 20% lipid emulsion, 10% amino acid solution, 50% dextrose, and you have to add 1 gram per 250 ml of NaCl. Then insulin should be used to prevent hyperglycemia. And of course, you have to follow these patients closely. Average blood glucose should not exceed 150 milligrams per deciliter. Maintain blood glucose between 110 to 150 milligrams with insulin, and you must prevent hypoglycemia in these patients. Now, there are different kinds of lipid emulsions available in the market. So one can go for fat emulsions containing various mixtures of long, that is soybean, and medium chain triglycerides like coconut oil and olive oil or fish oils are available. SMOF, that is soybean oil, medium chain triglycerides, olive oil, and fish oil. So these are really good for the patients. Monitor lipid infusion. Stop lipid administration when triglycerides exceed 400 milligrams per deciliter. Infuse over 18 to 24 hours. Monitor liver function test in these patients. The most common complications of parenteral and enteral nutrition are increased bloodstream infections, then metabolic abnormalities like hyperglycemia, hypertriglyceridemia, refeeding syndrome, problems related to venous access, more expensive. These are more expensive than the enteral feeds, and patients may not be able to tolerate the volume load because they have limitations. Then thrombophlebitis when parenteral nutrition is administered through peripheral line, and hemodynamic instability can be there. Severe fluid and electrolyte imbalance. Sepsis or systemic inflammatory response syndrome is a relative contraindication to parenteral nutrition, and the volume overload, of course, is a major problem, and renal failure without dialysis is again something that one has to look forward to. So the take-home message of my talk is prevent, monitor, and treat malnutrition. This is an algorithm which is talking about nutritional screening, the nutritional assessment, and then you go on, you give a good dietary advice, and accordingly, the patient must visit the dietitian for a good follow-up. If the patient is not doing well, then switch over to IDPN or enteral nutrition, or if the patient is hospitalized, then the IDPN and total parenteral nutrition, depending upon what the patient is going through. And of course, one has to, parenteral interventions that I've already spoken about. So low protein diet in CKD stages 2 to 5 non-dialysis can retard progression of renal failure and delay time to dialysis. Plant-based diets can alleviate hyperphosphatemia and metabolic acidosis, improve blood pressure control, insulin sensitivity, lipid profile, and reduce proteinuria. Very low protein diet with ketone locks and preserve nutritional status. Monitor potassium to prevent hyperkalemia. Excessive protein restriction without monitoring of nutritional status can lead to malnutrition. And thank you for your attention. So the study group, I think we'll conclude our day. If you have any questions, you can ask me later on. Or and if you have any clarification, if you need any assistance, you can always contact me anytime. And so we meet tomorrow again at 3 o'clock for our next day's lectures. And bye-bye for now.